Hello everyone and welcome back. My name is John. I'm one of the final year critical care fellows at Dalhousie University. Thank you so much for tuning in today for part 5 of my 7-part learning module on oxygen delivery and oxygen consumption for the evaluation of oxygen balance in hypoxemic respiratory failure requiring VV-ECMO. Last time we had a brief overview of the VV-ECMO circuit, and today we'll be discussing hemoglobin, pulse oximetry, and overall oxygenation. The objectives for today's lecture include discussing the role of hemoglobin in oxygenation, to discuss the factors that contribute to the shape of the oxyhemoglobin dissociation curve and how these contribute to oxygen loading and unloading onto and from hemoglobin, to discuss the technology behind and role of pulse oximetry in assessing oxygenation, and just to discuss the shortcomings of pulse oximetry in assessing overall oxygen balance. To begin, let us discuss the role of hemoglobin in oxygenation within the body. As you likely remember from school, hemoglobin is a protein found within red blood cells, which is responsible for carrying almost all of the oxygen within the body. Hemoglobin is critical to oxygenation because at physiologic conditions, oxygen has very low solubility in liquid, including blood. Hemoglobin is composed of 4 subunits, each containing a heme group in addition to a globin chain. The heme group is composed of a porphyrin ring featuring an iron atom at its center. The importance of this iron atom is it allows for the reversible binding of oxygen, which is critical for oxygen transport. Each molecule of hemoglobin can bind 4 molecules of oxygen, one at each of the 4 iron atoms. In the absence of oxygen, hemoglobin exists in what is referred to as a quote-unquote tense state, which is depicted poorly here on the left. This tense state configuration, interestingly, has a lower affinity for oxygen binding compared to the other forms. When oxygen begins to bind, however, the overall 3-dimensional structure of hemoglobin begins to change as the 4 subunits begin to interact with each other, adopting a structure that is referred to as a quote-unquote relaxed state, which is represented in the center and the rightmost images. This conformational change to the relaxed state results in several changes to the properties of hemoglobin, including increasing the molecule's affinity for oxygen, as well as changing its absorptive properties. Because oxygen can now more easily bind, there is comparatively smaller increases in partial pressure of oxygen required for each subsequent oxygen molecule to bind to each remaining vacant heme unit. This relationship is an example of something called positive cooperativity. And with this phenomena in mind, we can begin to make sense of the sigmoid shape of the oxyhemoglobin dissociation curve depicted here. Specifically, the flatter lower leftward portion of the curve shows comparatively little change in overall oxygen saturation on the y-axis for relatively large increases in PaO2 on the x-axis, reflecting the decreased affinity for oxygen in the deoxygenated tense state of hemoglobin. This is in contrast to the steeper middle portion of the curve, which demonstrates greater change in oxygen saturation per increase in PaO2, reflecting the increased binding affinity for oxygen once oxygen begins binding. As mentioned, while blood passes through the pulmonary circulation, it is exposed to high levels of dissolved oxygen, or PaO2, at the level of the alveolar capillary membrane, encouraging binding to hemoglobin even in the tense state. This environment is mimicked via ECMO as blood passes through the membrane lung. Sweet gas, which is a mixture of oxygen and air, although often 100% oxygen, is passed perpendicular to the blood, as depicted in the image on the right. As the tubes are made out of a special membrane that allows for the passage of gas but not fluid, oxygen is allowed to dissolve into the blood. Because the sweet gas has no CO2, the diffusion gradient is such that CO2 is encouraged to dissolve out of the blood where it is swept away by the sweet gas. The idea here is that oxygen is available at such high partial pressures within the blood at the level of the membrane lung or oxygenator that it is able to overcome the lower oxygen binding affinity of unsaturated hemoglobin, allowing hemoglobin to pick up oxygen and maximally saturate. In the peripheral circulation, the PaO2 is much lower than in the pulmonary capillaries or in the membrane lung. At the organs, first, the small amount of oxygen that remains dissolved in blood is extracted from the blood as it diffuses along a concentration gradient out of the blood and into the cells of the organs that are continuously using oxygen for their metabolic processes. This is depicted in the image on the left. Because oxygen bound to hemoglobin and oxygen dissolved in the blood exist in some equilibrium with each other, as the PaO2 falls further within the blood, oxygen bound to hemoglobin will eventually be released into the blood, represented in the center image here, increasing the PaO2 of the blood at this point. That oxygen is then allowed to follow the same concentration gradient as it flows out of the blood and into the tissues to support the organs in need, represented in the rightmost image. While the partial pressure of oxygen, the PaO2 in the blood at different locations within the body, does play a role in determining when oxygen is released from hemoglobin, there are several other local factors that impact oxygen's binding affinity to hemoglobin, which can either encourage the release or uptake of oxygen from or onto hemoglobin. The environmental conditions that decrease oxygen binding efficiency to hemoglobin, that is, encourage the release of oxygen from hemoglobin, include increases in temperature, decreases in pH, so a more acidic environment, increases in PCO2, and an increase in something called 2,3-diphosphoglycerate. These conditions can be thought of as consequences of metabolism and as such would be expected to be present in a higher degree at the level of functioning organs. This makes a lot of sense as these products of metabolism serve as a type of signal to offload oxygen from hemoglobin where it's needed the most, and that's at the level of metabolically active organs. All in all, these factors, along with decrease in PaO2, decrease the binding affinity of oxygen, and as such encourage the release of oxygen from hemoglobin into the blood. This change to binding affinity is typically represented on the oxyhemoglobin dissociation curve as a quote-unquote right shift. Factors or overall environments that increase the binding affinity of hemoglobin for oxygen result in a change to the oxyhemoglobin dissociation curve known as a quote-unquote left shift. To work through an example, if we use the oxyhemoglobin dissociation curve and work out an expected oxygen saturation for a PaO2 of 60 millimeters of mercury, we see an expected oxygen saturation of about 85%, noted with the red line here. If we were then to put that hemoglobin in an environment of a metabolically active organ, however, increased temperature and more acidic with higher partial pressure of carbon dioxide, all which are factors that we know decrease the affinity for oxygen and shift the oxyhemoglobin curve to the right, we see that the projected oxygen saturation is now only 78%, denoted with the green line. This difference here represents oxygen offloading from hemoglobin as a consequence of environmental conditions. Of course, the converse is true as well. When the hemoglobin exists in an environment that is less acidic, with less carbon dioxide and lower temperature, such as the environment within the lungs, the curve shifts to the left and oxygen binding affinity increases. These environmental conditions take a PaO2 of about 60 millimeters of mercury, corresponding to an oxygen saturation expected of about 85%, and elevate it to an oxygen saturation of 92%, seen here in the green line. With these concepts in mind, we can now switch our focus to discuss pulse oximetry. You're likely familiar with the use of pulse oximetry, which is a technology used in nearly every patient during some point of their ICU admission, if not continuously throughout their admission. As you know, using pulse oximetry is simple and involves placing a sensor on the patient's finger, toe, earlobe, or more recently forehead. As mentioned earlier, the technology behind pulse oximetry utilizes the fact that oxygenated and deoxygenated hemoglobin absorb different amounts of light at different. The pulse oximetry sensor contains two light-emitting diodes, or LEDs, one producing light at 660 nanometers and the second at 940 nanometers, that transmit light through a patient towards a photodetector on the other side of a region of capillary tissue. In the case of fingertip pulse oximetry, the photodetectors measure how much light is successfully transmitted through the patient's finger, allowing a microprocessor to calculate the absorption. The measured absorption value is used to calculate the absorption ratio, which is compared with the lookup table comprised of experimental study data from healthy human volunteers allowing conversion of the absorbance ratio value to a percentage, which is typically displayed on a screen. Interestingly, part of the reason that SpO2 readings are described as less reliable at saturations under 85% is because there's no experimental data to validate such values, as ethics approval to subject healthy volunteers to such low levels of oxygen is difficult to obtain. Although unquestionably useful, pulse oximetry is not without its limitations in the assessment of adequate oxygenation. Two examples of situations where the shortcomings of pulse oximetry are particularly apparent is the use of it in the setting of severe anemia and low cardiac output states. As mentioned previously, the pulse oximeter ultimately serves to determine and display an oxygen saturation as a percentage. This reflects the percentage of arterial hemoglobin that is saturated with oxygen at the site of measurement. And we then usually extrapolate these results to the patient as a whole. From time on the unit, we're all used to striving for oxygen saturations of at least 90 to 92 in most patients without pre-existing lung disease, or within an 88 to 92 range for those patients with certain pre-existing or ongoing lung pathologies. We strive for these ranges because we generally consider them safe, and more specifically, we generally consider the ranges adequate to keep patients out of anaerobic metabolism, which we know is hazardous. However, if we think back to our discussion about hemoglobin from earlier, we can recall that the main purpose of the hemoglobin is to overcome the fact that oxygen has such poor solubility in blood, as hemoglobin serves to carry a significant amount of oxygen that would otherwise not be possible to be dissolved in the blood. Under normal conditions, hemoglobin ensures enough oxygen is able to be transported to the tissues in need. Now, if we think about a patient who has a very low hemoglobin concentration, perhaps in the range of 10 grams per liter, we can begin to appreciate that with such little hemoglobin available, there now may be not enough hemoglobin available to transport oxygen to the tissues in the body that are in need. It's important to realize that because pulse oximetry is only capable of detecting the oxygen saturations of hemoglobin, the reported oxygen saturation as determined by pulse oximetry for a severely anemic patient could easily report an oxygen saturation of 100%, which would technically be accurate. This is obviously problematic, as this high oxygen saturation value may provide a false sense of security regarding overall oxygen balance, as it does not provide any information about the fact that the patient is severely anemic and therefore may lack enough oxygen carrying capacity to keep up with the oxygen demand of vital organs. To state this a different way, pulse oximetry, while extremely helpful, only tells us about the percent of hemoglobin saturated with oxygen and gives us absolutely no information about a patient's hemoglobin concentration, thus falling short on estimating oxygen carrying capacity in anemic patients. In addition to the shortcomings related to anemia, we can think about a patient who has a low cardiac output state next, perhaps related to cardiogenic shock. We can all likely recall a patient we have cared for in the past who was quote-unquote peripherally shut down, a term used to describe a patient who is severely vasoconstricted in their periphery as the body clamps down on peripheral vessels in an attempt to preserve blood pressure to the vital, typically central organs. It can be difficult to register oxygen saturations in these patients when their circulation to their periphery is so poor, which makes assessing oxygenation difficult. Important to remember is that, much like in the case of severe anemia, even if we were able to register an oxygen saturation that appeared adequate, this might not be telling the entire story. Again, because the pulse oximeter can only measure oxygen saturation of hemoglobin, it is unable to inform us of issues with circulation that impact the transport of the oxygenated hemoglobin around the body. For reference here, we see a situation where there is sufficient flow and sufficient oxygen to supply the entire pictured organ here, represented with the liver. We can see on the left that the fully oxygenated hemoglobin flows through this capillary bed and is offloading oxygen, and even by the time it completely passes by the organ, there's still some excess oxygen left. This is pretty typical. In a setting of low cardiac output, however, because the blood is pumping so slow, there may not be enough transport of oxygen per unit time to sustain normal metabolism at the level of these organs. Worded a different way, because blood is moving so slowly in cardiogenic shock, the oxygen contained in it may be completely exhausted before supplying the entire organ. It may not be replenished in time to avoid tissues from having to rely on anaerobic metabolism in the lactic acid cycle for fuel. A similar problem with waste, carbon dioxide or lactate removal, could occur as these products of metabolism can be produced at rates that exceed the rate at which they are cleared. Both of these situations bring the possibility of organ damage from hypoxia. And with that, we've reached the end of part 5 of our learning module. In this section, we discussed the role and importance of hemoglobin in oxygen transport. We also discussed the factors that lead to the characteristic shape of the oxyhemoglobin dissociation curve and the factors that both increase and decrease the affinity of hemoglobin for oxygen. We also reviewed the technology and principles behind pulse oximetry and discussed the shortcomings of pulse oximetry in isolation or the assessment of overall assessment of oxygen delivery. Thank you for your attention. I hope you can join me for part 6 of this learning module next, where we will be introduced to the concepts of oxygen content, oxygen delivery, and oxygen consumption.